Hello, welcome to the Cabot Technology Solutions Healthcare webinar. I'm your host, Shibu Basheer, and I would like to welcome Adam Tobbe, co-founder at PAC IQ. Um, PAC IQ is a startup that was originated 2 years ago. It helps in the referral management system with our hospitals and long-term acute care centers. Adam, if you could, tell me a little bit about yourself and PAC IQ and how it all started. What was the inspiration behind it? I'd love to hear from you.
All right. Well, we only have an hour, so I'm not going to go all the way through it. But Adam Tobbe, I'm a clinician by background, registered nurse. So grew up in the trauma emergency medicine space. Transitioned over into more of the technology role about 10 years ago, maybe a little bit less, 8 years or so. And then really started getting into the post-acute space about 6 years ago. So I was originally brought in to start looking at solutions to problems, right? And they were kind of unstated problems. It was, we know that there are opportunities for improvement. We don't know exactly what they are. We don't know if there is technology out there that can assist with what the struggles that we're going through today. We just need help. So our incubating client and where we kind of grew up basically turned us out and said, find a problem and fix it. And let's look at the ROI and let's go for another and another and another. Referral management for my team, Lee Jones and Tasha O'Brien, also co-founders of the company, became a really hot ticket item for us right away. I think the very first meeting we sat in, pretty sure after about 2 hours, there were tears of how frustrating the job can be. Managing multiple different systems, trying to read through all of the documentation, trying to understand what the capabilities of the clinicians that are working in the community are. And unfortunately, when you don't make a good decision or you omit something or overlook something, fingers get pointed back to you because you were ultimately the one who said they could come in. So we identified that there were a lot of problems there. So we started really looking on the market for technologies that could assist, not just as a CRM, not just as capturing the referrals and making sure they were being documented, but to really help with that workflow challenge that we were identifying. Unfortunately at the time, or fortunately, I guess now, 4 years ago, there wasn't really a solution on the market that did everything that we needed it to do. So we have a scrappy team of 8, and we started just slowly tinkering and developing. And we got it to a point where we were actually starting to see some really good benefit from what we were creating. Lee and his team, phenomenal technologists, were essentially able to build us a beta version of a product using Microsoft Power Apps and a few different other kind of tools plugged into it. And it was one that just continued to grow over time. As we identified more pain points, we would go and we would develop new solutions. And we just kind of bring everything back together into a product that really we started to get excited about a few years back. And we started to realize that this is something that not only is it benefiting the company we were with at the time, but it's also got broad application across the industry. Fortunately, that's where we had a little bit of approval and we had some wind in our sails, and we were able to be introduced to you, Shibu, and work together to build out what we have today with PAC IQ, which is kind of a one of a kind, if you will, solution that really tries to take the workflow and create automation, bring referrals into the platform, use those workflows to really save time, save effort, and save energy from the clinicians and non-clinicians that are using it, and then also provide a significant amount of transparency on the back end to make sure that the strategy is essentially working. So we introduced Referral IQ onto the market a little over a year ago, and so far so good. We're continuing to grow. Obviously, when you build something for one person, somebody else wants it a little bit differently. So we've been able to be very nimble and develop out something that fortunately has had a pretty significant impact for many that we've introduced it with.
That's great. So both you and Lee and the rest of the team, you all have been you're registered RNs, right? So
Correct. Yes.
you have gone through the experience And then is that how you found there's a need in the industry, or was it was it through research or folks in the industry that told you that this is a problem that we need to solve, or was it a personal issue that you are facing on a day-to-day basis that you
Um,
found that needs to be resolved?
I can honestly say that this was one of those that we almost had to go into kicking and screaming. We knew the complexity of the problem, and we knew how much it was going to take to try to provide a solution to it. There were other little solutions that we wanted to try instead, and ultimately there just wasn't anything out there that matched the need. So I learned about it in multiple different ways. Actually, back many years ago, I was actually responsible for admissions at a post-acute community. So I was one of the senior leaders within that organization, within that specific community, actually. And somebody would every once in a while hand me a packet of paper and say, "We need you to review them." Um, Typically speaking, 70 to 200 pages. It was a good day
Yeah.
if they put a binder clip on it to try to keep track of it. And then I had a stack of highlighters, and I would go through and I would start highlighting information that I thought was important. It would generally be, if you were really trying to advance one of these, one of the records through, you could do a quasi decent review in 20 to 25 minutes. If you really needed something thorough or it was a more complex patient, you were really looking 30 to 35 minutes. Um, and even still, there were many that I got chastised and you missed this, you missed this. We don't have the capability on this unit to be able to do that. We don't have that type of bed available. So there were still a lot of things that kind of fell through. And then you would come to learn that, in the time that it took you to do that, one or two referrals, there were three or four additional that were received. So the job becomes kind of never ending and compounding. So the baptism by fire really was having to do the job every single day. And I remember thinking many, many years ago, boy, it would be a lot easier if somebody would just go through and kind of curate this for me so I could make a
Yeah.
decision and clinically make a decision, as opposed to having to go through and just read, right? I'm just reading information constantly, and trying to figure out how to synthesize that information. So a couple of other areas, it was one of those problems that we just couldn't escape no matter where you were in post-acute. Um, I worked for some national providers, regional providers, and the problem was really the same. I think as I went into my very first national provider, they had a footprint in, I think, 46 states at the time. I didn't know that they would have the same problem that I had in that one community. They still did. Now they moved the problem around, and they had a centralized area, essentially a warehouse where a bunch of clinicians would sit there and just read the documentation for them. And that was the first time that Lee and I really started to tinker with potential solutions of, well, maybe we can make life a little bit easier here. And it wasn't until we started working together officially full time on the problem with a different provider that was a regional provider that we were able to start creating solutions. So it's been one that's plagued the industry for a very long time. I've got the personal experience from seeing it plague the industry. Um, but it's definitely one that, no matter what position in healthcare you're in, if you're a case manager in a hospital or a registered nurse on a floor, moving patients through the continuum is difficult. It's challenging. There's a lack of transparency and communication. There's a wealth of knowledge out there. It's just there's not enough people to go through and really disseminate what the knowledge is. So those are some of the big challenges that we've really had to address. And as the old adage goes, it's you're trying to change the wings on the plane as you're flying, because you have to continuously think different, but you don't have the ability to go lock yourself in a room and pontificate for 2 years on what the potential solution is, because you still have a day job to do.
Yeah, yeah. Okay. And the way that you guys did it was you put together a prototype with Power Apps and
Yeah.
so on. And you guys did a lot of magic beforehand, before you went out and asked for help from an external party.
Mhm.
So what brought the confidence within the team that yes, this is a problem that we can solve, and there are customers who are willing to pay for it. Let's go spend the money
Yeah.
and build it.
So a couple of shout outs, Lee Jones, who I've mentioned, and Dustin Shalala. Dustin is a phenomenal person, and he was brought into the department at the time, for a pretty simple task, and his job was to move data from point A to point B. Um, One day we realized that Dustin got significantly faster and faster and faster, and we realized, as he was very proud to say, he was using a script to help him do his job a little bit more efficient. We had always had the idea that we could leverage technology to be more efficient. It wasn't until we all started to sit around and break the elements down into digestible pieces of, well, maybe we can do this, maybe we can do this, that we started to put it all together. And really our initial version, our beta version, was the confluence of all of those ideas coming together to say, we know how to fix this little piece and this little piece, so let's plug a person into this part and bridge that gap. And then we can fix this piece over here, so let's bridge the gap with a person again. And then we started trying to pull the people back out of that process. So essentially we had to make it work where we couldn't figure out an automation. We would rely on a person. And then as we could automate that, we moved them around to other areas within it. And within the organization at the time, what we would actually do is we would just take on a larger scope as we could automate positions out. We would go out and expand. COVID had a large part in that as well. We were essentially asked to expand from a pilot of 6 communities to 60 communities overnight. So a pretty significant growth for us. Fortunately, we were able to handle it. It was a little rocky for 24 hours. But we were able to handle it in a pretty streamlined fashion soon after, and once we got our feet under us. So actually, a competitor or a quasi-competitor was purchasing one of the buildings that we were using the application in. And it was at that point that we started to realize that this may have applicability outside as well. They got very excited about it when they saw it. Said, is there any way we could potentially purchase it? And Lee, Dustin, Tasha, and I kind of sat around, looked at each other and said, no, there's not really a way we can do this. So we knew at that point that if we could support the industry in some way, we needed to expand our horizons a little bit more and really get outside of this little universe that we created for ourselves, and find somebody who could really help take our development to the next level. So again, I think we got a good start on it. We didn't know what to do after that. So that's where we went to the market and said, we've got an idea, we've got a concept, not just, a high level. We had a working application, and we basically said, go recreate this, and let's see what we can do with it. Now I would be remiss to not say that there was a lot of a learning that we had for that first real, probably 9 months that it took to build it out. Because I think what we went in with our beta product, it was okay, but there was a lot of dramatic change from our beta product to our actual first release product.
Okay. Yeah. And could you tell us a little bit about the patient administration process? The referral process. What are the typical bottlenecks that is found in this process? And how does PAC IQ solve them?
Yeah, so it really varies from every single provider that you'll talk to. I've had the fortune of talking to probably close to 100 different providers at this point, if not in the high 60s, 70s. Everybody does it a little bit differently. So some of the big challenges that the industry has today is referrals kind of find their own way over to these communities. So there are multiple different e-platforms that can send a referral over. We try to integrate with as many of those as we possibly can, and then we kick off our workflow. So depending on how a community or a network is structured, really, or a provider is structured, they could have a central intake. They may not have a central intake. Their central intake may be clinical. It may not be clinical. They may have the ability to accept or deny on behalf of the building. They may just be kind of there helping to go through and find the details that they need to find. So inconsistency was the only consistency that we could find in the industry. But you have to start from somewhere, right? So we tried to go out and kind of conceptualize the 4 or 5 different models that we find providers using, and we tried to build a solution for those. Through learning, we can find out that those 4 or 5 broadly apply. There's still little intricacies within each of those providers. So the overall process, it's labor intensive. It's very manual. Like we talked about, it can take 25 to 30 minutes to go through and read a clinical documentation. You have to go and verify insurance. You have to, for most states, do a sex offender registry check to see if the patient's even eligible to admit. You have to be able to correlate the available beds that are in a community to understand if you can actually accept the patient. It's incredibly labor intensive. And unfortunately, there's not an abundance of nurses that there were 10 years ago. So standing up this warehouse in the middle of nowhere and staffing it with registered nurses who can read documents all day, it just doesn't work anymore. It's very, very challenging to staff. It's very expensive to staff as well. So what we do is we try to really leverage the power of centralization, technology, and automation to allow providers to work with a significantly smaller footprint as far as the FTEs go that are dedicated to it. As a clinician, I've kind of dedicated my life to being in front of a computer because I don't think that's where clinicians always belong. I wholeheartedly believe that clinicians are happiest at bedside. They're happiest interacting with patients, and that's what we went to school for. That's where I spent the first years of my practice was to I wanted to spend time with patients. I wanted to help people who needed my help. And what we started to realize is, I can be mad about having to use technology or the lack of technology, and I can still go spend time there, or we can help be a change in the industry and really try to allow others to be able to spend that time as well by bringing solutions to the market.
I'm just adding Lee. He just joined. I also wanted to take this opportunity to kind of say to the viewers, we'll be taking questions. So there is a question and answer section in the chat in Teams where you can ask your questions, and towards the end of the call, we'll be reviewing the questions. Yeah, welcome, Lee. Thanks for joining in.
Hello, thank you. The job never ends.
All right, I'm bringing you to the screen, Lee. All right, say hi, and then I'll take you off.
Hello, everyone. Sorry about that.
Lee Jones is also one of the co-founders of PAC IQ.
Yes, well,
yeah, sorry.
We heard a lot about you already on the call.
Oh, all good, I hope.
All good. Thanks for joining in. So, Adam, can you also, you mentioned about the patient experience. You wanted to spend more time with the patients, right? So can you tell us a little bit about how does it directly, affect the patients? What is their experience going through the journey? Is this making an impact for them?
Yeah, absolutely, in my opinion. The patient never interacts with our technology directly. We exist kind of in the background. They'll likely never hear about us. They don't know, generally speaking, what a referral management platform is. They don't know how the magic works behind the scenes. And honestly, that's ideal. What we hope happens is there's a more seamless interaction as a patient is leaving an acute care community or acute care hospital and going to a community. Our goal is to make that faster. And our goal is to also make sure that when they arrive at that post-acute community, that there's additional face time that they may not have otherwise received. So our goal is to always kind of push the boundaries of what we can do with automation and technology. So somebody is there to smile at them when they walk through the door or rolled through the door. They're greeted by somebody in the admissions department because the admissions department has the ability to do so at that point. Our goal is to make sure that the case manager at the hospital isn't hunting for hours to see if they can find placement because nobody's responding back to them. We really want to make sure that the amount of time spent in front of a computer for a clinician is minimized as much as possible. Obviously, we're a small part of that, right? So there are some that it's going to have a dramatic impact, and there are others that it has minimal impact. But yeah, our goal is that a patient doesn't really need to know that there's an entire process going on, because all that they know is when I left the hospital, the case manager came down and said bye to me and smiled. And when I arrived at my new temporary home or permanent home, I was met at the door with a smile as well. So if we can do that, then I'd say mission accomplished for us.
Okay. And how is the ROI for the provider when you go and pitch the product to the providers? What is the ROI for them? How does it help them?
That's an interesting question, and it could be answered in numerous different ways. It almost depends on the pain points for the provider that we're talking to. Many of them, as we're going in, this has been pretty interesting and a learning experience for us because none of us are salespeople. We are probably the worst salespeople you'll ever meet because we don't talk about sales. We talk about something we're very passionate about, which is technology and how technology can better the industry. as we go in and we have these conversations, we go through and we show everybody what we do every day. We show the power of automation. We show the power of centralization. Generally speaking, as we get to those kind of quote unquote ROI slides or the outcome slides, most providers don't really care at that point. You've already solved the problem. They know that they have that problem every single day. They know they don't have enough staff to do this process. They know that there are pieces of the process that are being dropped. So when we get to the ROI side, they say you don't need to prove the outcomes to me because I already know what the problem is. So some providers really try to judge it by an increase in census or an increase in admissions. They could look at it from a reallocation of staffing. If they don't have enough staff already, they can potentially look at downsizing the size of some of those departments and moving people into other departments. Seeing how they can flex in some smaller buildings with not having, if they can't hire an admissions person, how do we move some of those responsibilities to others? We have one phenomenal customer who is actually in a quasi-centralized, decentralized centralization model, which is very confusing. But essentially, they have kind of roll-up coverage that'll happen in some of their communities by somebody in another community. It's not a primary responsibility, but they jump in and help out because they're all in the same system. So as long as they give them access to it, they can actually jump in and help one of their coworkers who could be 300 or 400 miles away go through and really try to drive the efficiency that they need to. So it was a really cool model that we didn't necessarily build for it. And we didn't really know that they were even doing that until we were informed of it. And they said it's working really well for them. So yeah, I mean, it's the ROI is kind of, it's multifaceted. It's a difficult question to answer. But kind of everything that I just mentioned, we tend to see an impact there.
Okay. Okay. And how do you use AI in PAC IQ, and what are customers saying it? Are they receiving it well, or are they pushbacks or concerns?
I think overall, everybody has received it very, very well. We've tried to be very in front of the limitations of AI. AI is not here to solve all of the problems, and we tell everybody it's not here to automate the work away, right? It's not here to take the place of a clinician. What it's here to do is to help that clinician understand what they're looking at. So it may tell you that the patient's on a ventilator and you need to go in and dig a little bit deeper into understanding what's there. So we've leveraged AI in numerous different ways. Probably the most powerful is just in helping a clinician be served a story. Sometimes that's the most important thing, is to really get that synopsis of what's going on. So you can go into it with a frame of reference of going a little bit deeper. We've also looked at AI in some of the more kind of mundane tasks, data entry. So as referrals are coming across, as opposed to having somebody do that initial data entry on the front side, how do we create those automations where we can go pull the patient demographics down, we can pull the insurance plan down, we can try to take the place of some of that typing that needs to take place, and use AI to leverage that. So I think AI is incredibly exciting, and Lee can absolutely attest that until probably 6 months ago, I was pretty hard against it. I didn't think it was at the place that it needed to be, and I didn't think our customers were really ready for what we wanted to do. We had a pretty grandiose vision of it, and I didn't know that the technology existed at the time. And I think with 4.0, 4.0 Mini, and some of the newer AI models that are coming out, I think we're finally starting to crack it. I think there's still a lot of work to do. I think there's a long way to go with what we can do with it, with AI, but I think we're getting into its infancy of what it's really allowing us to do. Fortunately, it's been impactful so far. Most of our customers are kind of dipping their toes very carefully, and they're coming into it relatively skeptical, which is our recommendation. And they're saying, well, let's start with a few kind of overarching clinical questions that we would want to go ask. And then that way they can feel comfortable with it. And Lee and his team and Tasha and her team have been phenomenal about helping to gradually introduce what the capabilities are and make sure that they're comfortable with it in the first place. Like I said, we're not great salespeople. We're not here to sell anybody anything. We're here to educate and inform about what our capabilities are and what we do differently. AI is one of those areas that we're really investing the future of our company in. It's not to take place of the workflow, and it's never to get rid of a clinician from the process that they're in, but it's really to help them more effective so they can be front and center with patients as patients need them.
Okay. Well, and Could you tell us a little bit about your, the team's entrepreneurial journey, taking from the idea from concept and all the way to production and to customers and scaling it?
Yeah, so I know we hit on that a little bit, kind of what we've done in the past. I think the most critical element for us, and this is not designed to be a plug for Cabot, I promise, the most important element for us was finding a partner who could share our vision. And for us, we had, an application that was running in Microsoft, and we knew what we wanted it to do. We knew it was possible, but we needed to find a partner that was willing to work with us and really explore it. And that's a challenge to find. It took us a solid almost year to go out and really build out what we had envisioned. And while we do have a very, very, very capable, very functional product today, we know that there's still much, much more that we want to do with it based on just our own aspirations and based on what our customers are asking for us. But that's where really finding a technology partner who aligns with your kind of mission, vision, and values, right? That's one of the most critical elements, because enveloping in a bad partner or somebody who just doesn't quite get it is detrimental to the forward momentum that we have, right? To swap a technology partner at this stage would be next to impossible for us, and it would be a 6 to 8 month slowdown of what we're trying to do. And we've got an industry that has been underserved for as long as we've been in it. There are many of the technologies that they use today were not really designed for their specific use case. It was something that was designed somewhere else, and somebody just said, well, we could probably make money if we slap a new badge on it and push it over into this side of the industry. We really didn't want to build something like that. And as we've talked about with our customer base and prospective customers, we've tried to build it with them specifically in mind. So instead of looking at the problem kind of top down, looking at it from the acute care perspective down to the acute care or post-acute perspective, we've really tried to look at it from the post-acute perspective up and say, we know what we need to be successful. We need to try to meet in the middle with our acute care partners to make sure that we can be more efficient and effective. One of the things that I can say personally is I've been on the receiving end as you're having a conversation with the hospital, is they're looking at your referral metrics and scolding you for not doing a better job than you did when you're doing everything you possibly can. That needs to be a dialogue, not a punitive conversation. So we've really tried to build solutions that can help really empower the industry to not only get their voice back after it's really quasi been lost, but so they can really take the data and make an impact and try to make their communities a better place.
Okay. This is probably one of the last questions. And among our viewers, there's a lot of startups who are looking to build new products in the healthcare industry and bringing it to the market. Do you have any advice to them on how they can be successful? And what are your learnings and your thoughts on how startups can be successful in the space?
Many would probably say, well, that's kind of a cop-out answer, but I believe this sincerely and 100%. Try to do the right thing.
Mm-hmm.
If you do the right thing for your customer base, they will be your biggest advocate. If you do the right things for your employees, they will be your biggest champions and supporters. If you do the right things by your partners, your vendor partners, your technology partners, they will go to the mat for you. Try to do the right thing and go into it with the attitude that if the industry is ready for it, it will work. Sometimes you have to convince the industry that they need it and that they are ready for it, because there's a difference between wants and needs. And specifically in the post-acute industry, they want a lot of things. The post-acute industry is not one that is flush with revenue. So there's not a lot of people out there who are willing to write a massive check for a technology. So just because they want it doesn't mean it's something that they get to have. So you really have to find that Venn diagram between wants and needs and abilities to really be able to deliver something to the industry. Healthcare is a challenging one to get into. There's a lot of regulation. There's a lot of process that's already in place, because it's, as we talked about with changing the wings of the plane in the middle of the flight, they haven't been able to stop and say, well, let's go build something and then see how it works, because they do have a job that they have to do every single day. and any adoption of a technology or any even exploration of a technology will disrupt time. And I think that's something that the industry, specifically post-acute industry, I hope that's something that they really open up to, is sometimes it does take a time investment to really understand what the potential is. Not everybody's there. I think most that we've had conversations with get very excited about the prospect of what's coming in the future in general. But I think it's all led with just go at it in a good faith effort. Work with your partners, work with your customers, and be the type of partner you would want on your side, right? I think that's probably the most important thing. That may be a cheap answer, right? Like, but I truly believe that that's the way that you find success is people want to partner with somebody who knows, understands, and they feel like they connect with. And again, if that's not what you're about, then specifically healthcare is going to be a tough industry to break into because they're not about the point solutions that don't really solve their problems.
Yeah, do the right thing, and your partners will take you, to next heights, right?
Yeah, absolutely. A rising tide raises all ships, right?
Yeah.
So,
yeah. I do have some questions here. We are, going towards the end of our call here. Ikshit is asking Adam, have you solved all the problems in long-term acute care center, and what are some of the new problems that you're looking to solve with PAC IQ?
have we solved all of the problems? I think we've hit 0.001% of the problems. I think we're focusing our efforts on a very big problem. And this is not a knock on the post-acute industry whatsoever. I think I mean, gosh, you could say that about the world, right? There are always going to be problems. There are always going to be, let's say, opportunities that we can look at. The future is bright. The future is bright. I think there are what I've started to see a shift in probably the last 3 or 4 years where you have competitors who are actually starting to team up a little bit more. And they're going deeper on the problems that the industries are having. And I think the industry is getting louder. COVID was detrimental to post-acute care, but I think one thing that did come of it was a voice. I think people started to realize that a neglected industry is so critical. And as you started to see it go into dire straits there for a little while, I think people did get a little bit more protective. And I think the post-acute industry raised a voice from that. So I don't know exactly what the future holds as far as all of the other problems that do exist. What I can say is I think the future is going to get brighter and brighter, just because I think the industry for itself is really starting to speak up.
I have one more question for you, Adam. A viewer wants to know how a referral management will evolve in the next 5 years or 10 years. What further improvements can happen?
Yeah, with that one, I think our goal is always to get to a quote unquote single pane of glass. One of our customers told us that it's a kind of one-stop shop. Right now, it's a difficult process. There's a lot of different steps that need to have happen. I think between artificial intelligence and HIEs, health information exchanges, leveraging automation, I think there's going to be a lot of movement in the space in the future. I don't ever want to get to the point where AI or computers are making decisions and saying that, hey, this patient needs to go here. I think we can look at outcomes and really try to match the patient with the most appropriate community based on the patient's specific ailments, based on their specific needs. I think that's a great place for the industry to go. But I would wake up very disappointed in myself and in the industry as a whole if they try to take the people out of the process. People understand people understand capabilities. I think the computer systems need to be designed to help us understand what we need to understand. They're there to give us the full story. But I don't think you'll ever find a model that will replace not just the clinical appropriateness or the clinical understanding of what a patient is, but really the empathy that goes along with that as well. That's where I don't want to go. But yeah, I mean, again, just for referral management specifically, the future is very, very bright. It's been an area that's needed assistance for a very long time, and we're very happy to be leading the charge to say there has to be a better solution out there.
All right. I think we are reached all the questions, and we are also running, out of time. So I'd like to thank you, Adam,
Yeah, you bet.
for kind of joining us, and Lee, Adam and Lee for joining us, and um, also thank you for all the praises that you've made for Cabot, and we are looking forward to more and more solutions coming out of PAC IQ.
All right. Thank you so much, Shibu. It was great to talk to you today.
Thank you.
Thank you.
Awesome. Bye.